in the session. So welcome everybody to our session today, hosted by KeepMeSAFE. We'll be discussing a case that our colleagues have had in the ICU in Sudan, in Gaffer ibn Auf. We hope to cover the case itself and then open the floor for some discussions during the case presentation and towards the end. And we'll focus our discussion on at the end on constrictive pericarditis and also pediatric delirium. I'd like to introduce our speakers today. We have Dr. Safwa Osman, who's one of our medical officers in Sudan. She'll be presenting the case, and she took care of this patient when he was in the ICU. Dr. Nick Ettinger, who's one of my colleagues here at Texas Children's Hospital. He's a pediatric ICU consultant, and he's our sedation and delirium expert and is very interested in global health. And I'd like to introduce Dr. Hashim, who's a cardiologist in the UK. And even though he's an adult cardiologist, he has been generous enough to share his expertise in the pediatric realm as well. And he's a cardiologist at Nottingham University Hospital through NHS Trust. And without further ado, I'd like to open the floor for Dr. Safwa to start presenting the case, and we'll open the floor for discussion after she presents the first initial part.
Assalamu alaikum. Hello, everyone. Can you hear me? Okay, yes. Perfect. Sorry, okay. Thank you very much for Dr. Nak and Dr. Dalia, Dr. Amal for their priceless help to present this case. Actually, we're going to talk about brief background, the approach of the case, what was the differential diagnosis, the planned course of management of all his problem list, and the outcome of the case, going through the communication we had done for both other subspecialties and family of the patient. We're going through the challenges we had, and finally, the learning point from this case. Firstly, he was a brief background. He was 9 years old, fully vaccinated male, no case of asthma since the age of 4 years.
Safwa, sorry to interrupt you. I don't think you're sharing your slides. We don't see anything.
Okay. Not shared.
If you want, I can share from my end, Safwa.
I can do it. Let me try. Just to be controlling. So I can share. Hello?
Yep. Do you want me to share, you said? Or you got it?
Yes.
Okay.
Yes, please.
Can you see?
No.
Presenter mode, not the slides.
There we go.
Swap displays.
There we go.
Yep, perfect.
Actually, I can't see.
You can't see it from your end?
Yes.
You can't see anything now, Safwa?
Yes.
You want to log off and then log back in again and try it that way, or do you have it pulled up in the background maybe?
Safwa, if you go up to the top right of your screen, there's a little thing that says view, and it has a box with 3 dots on top. If you click on that, there's maybe go to swap video and shared screen.
Okay, I can see now. Thank you. Sorry.
All right. You ready for me to go to the next slide?
Yes, please.
Okay, here we go. So you'll go through the objectives. All right, here you go.
Yes, as I said, he was a 9 years old, fully vaccinated man, non-case of asthma since the age of 4 years on beta-2 agonist as required and on regular follow-up. Regarding his birth, nutritional, developmental, social, and family history, all of them were unremarkable. On arrival to Sudan Cardiac Center ER, sorry, it's not organized. Can you go further for the next slide and come back? Yes, please. On arrival to, no, the previous slide. Sorry.
This one?
After that.
This one.
Yes. On arrival to ER, he was brought to ER by his parents, presented with sudden shortening of breath, even at rest, associated with severe chest pain, which was pruritic in nature, along with cough, dry, mild cough for 3 days, and fever, which was described as intermittent, high grade, but not document the actual number of it, with no other associations for the 3 days also. Actually, the present illness started 20 days ago with a history of minor trauma to the left knee. For that, he developed pain, which increased with movement, with no swelling at that knee, for which he had a traditional therapy in a form of traditional splinting, but his knee got worse in a term of increasing of the swelling, pain, up to restrict his movement. Actually, it was a bit weird why from the start, he went to the ER of Sudan Cardiac Center because he was advised by a friend of a family to go there. On examination of this child, he looked ill, wasted, not pale, jaundiced, or cyanosed. His pulse was 140, regular, strong pulse. Temperature was 38.5. His saturation was 84 on room air. Respiratory rate reached 50 and more. His blood pressure was maintained between 90 and 95th centile. Regarding his weight, he was on the 90th of centile, height on 75 to 91. He was fully conscious with GCS 15/15. He was distressed in a term of tachypnea, as we mentioned, along with subcostal and intercostal recession. On examination of the chest, there was a right side dullness associated with poor air entry, and there was a mild wheeze on the left side. Cardiovascularly, there was a raised GVB with no murmur or galloping, with hepatomegaly 4 centimeter below costal margin. So actually, if anyone wants to join us in such a similar condition, what should be the approach and how we can deal with such patient on ER?
Thank you, Safwa. This would be a great spot to kind of pause and think about this patient and how he looks, and if this patient were to arrive in the ER, let's say in Bahri or Durman or wherever we have, thanks Nick, wherever we have ERs, even in private hospitals, how would this patient be managed and triaged? We'll open it up for discussion to see what our colleagues in Sudan would do, and then we'll open up the discussion for the rest of the group to weigh in on their thoughts. ناس السودان البيشنت ده كان جاكم في الحوادث، بنعمل شنو؟ بتفكيركم بيكون كيف؟ ممكن نتصرف كيف؟ ممكن نحوله وين؟ نخليه في is he cyanosis is a question. His SpO2, his saturations were 84% on room air, but no visible cyanosis with that, right, Safwa?
Yes, no visible cyanosis peripheral or central.
وده البيشنت ده جاء في مستشفى القلب، يعني ظهر لهم في مستشفى القلب، ما جاء في أي من حوادث الأطفال يعني. So what would we think? What would we do? How would we triage this patient? Would we transfer him? Would we not? Ni'ma is asking right lung collapse or right pleural effusion. Is this a question or a comment? معلش Ni'ma. Okay, so Nigda said she'll put him on oxygen first. In what form? What form of oxygen? Would you put him on nasal cannula or a non-rebreather, on BiPAP? Let's start with just nasal cannula. Okay, so asthma, pneumonia. Okay, so Taqa would start with a non-rebreather, thinking that this patient maybe has asthma or pneumonia. Okay. Would anybody do an X-ray at this point, or would you high flow? Okay. Chest X-ray. Okay. Perfect. Any of our PEM colleagues want to comment on how they would approach this patient if he were to show up in the ER? Khalid?
Hi. So this is not a very unusual presentation, isn't it? So just to sum up the history, this is 9 years old, who's fully vaccinated with prodromal illness, coming with symptoms of tachypnea, tachycardia. On initial examination, the patient is febrile, hypoxic. I think the blood pressure is all right. And I think from D point of view is all right. A bit distressed with symptoms and signs suggesting poor air entry and wheeze as well. So I think we'll start with the stabilization in any, so A to E. So A is open. B, the patient will need definitely high flow oxygen in form of rebreather, 15 liters at least. And we'll start then, again, we are in the breathing. I don't think the patient needs any form of respiratory support, but definitely need oxygen at this point. From circulation point of view, so definitely we'll need an IV access at some point, but for now, let's move on. And I think from D, we need to check the sugar. The differential diagnosis in this case, in general, will go from respiratory to cardiac mainly, but just because the patient is febrile, we'll think about infections with whenever the source of infection is. It can be chest infection, but also because you started the topic about pericarditis, we'll still think about that at some point. But I think if I'm sticking to the bread and butter cases, would go with respiratory, but again, thinking about cardiac causes in the background.
Thank you. Thank you very much, Khalid. This is pretty much everything that the group had texted in the chat as well. So they went through a very systematic approach to this patient. And like you said, bread and butter pediatrics, right? So always think lungs, the heart, and the patient seems to be in heart failure. So I'm going to ask a few questions to some of our colleagues who have posted in the chat, just to pick on them a little bit. معلش يعني عارفاكم كتبتوها بالchat، لكن لو قدرتوا بس تعملوا unmute وتتكلموا لنا يكون كويس خالص. So محمد الأمين, you said pulmonary embolism. What makes you think pulmonary embolism in this patient? And how would you, if you were to suspect this is pulmonary embolism, what would you do next for this patient? If you can unmute, that would be great. CT angio, okay. Okay, we'll get back to you, Mohammed, and we'll talk about the PE in just a little bit. Dr. Alawiya, would you like to comment on the heart failure? Can you unmute to comment on it, or would you prefer to type in the chat, since you mentioned heart failure? And would you do anything different now that you're thinking about heart failure? I think she might be texting then. Okay, we'll also come back to you then, Dr. Alawi, unless you have the distress, the desaturation, the hepatomegaly. Very good. Yeah, makes you worry. So would you do anything different? So would you manage this patient differently? You would still put an IV and you'd still put this patient on oxygen, but would you think to do something different if you're thinking heart failure? He's in the cardiac center, so lucky for him, he's in where he needs to be. So would your management change? You would start him on Lasix and nasal oxygen. Okay. Infective endocarditis, that's a very good one. Yes, absolutely. We see a lot of that in Sudan, of course. All right, so why don't we keep going just to see what ended up happening to this patient at the cardiac center. And then remembering that this is a pediatric patient who landed in an adult facility. So management is different than what we typically do. Go ahead, Safwa.
Okay. Actually, this was his X-ray on arrival to ER, which showing a hyperinflated lung with counting more than 8 trips from the midclavicular line and more of a straight trips, showing the massive right pleural effusion. Actually, it's almost pushing the heart to the other side. On left side, we can see there is consultations all over the left side with air bronchogram. That's why the approach was actually, as they said, starting with ABCs for the acute hypoxic respiratory failure. This was a first problem for him, based on both pulse oximeter saturation and even ABG. Along with acute severe asthma, as we mentioned, he is on a background of asthma, came with some wheeze. His second problem was massive pleural effusion, as we see by the dullness and chest X-ray finding. The third point was bit interest of pulmonary embolism. Actually, the diagnosis was dependent on the D-dimer and Wells score. Both echo and CT angiography were requested, but not available at ER level for this patient. And unfortunately, this will be a discussion point and a conflict point. Is it reliable to depend on invalid D-dimer factor and Wells score for a pediatric non-adult case to diagnose with BE? Put in mind that he couldn't do any of echo, CT angiography, or even ECG. So it will be discussed later. The first point or problem was osteomyelitis on the trauma knee, the left one, with swelling, redness, hotness, for which synovial fluid was taken. ABCD approach, as all mentioned. Actually, they reached 20 liter by non-rebreather mask for this patient, and chest tube was inserted. In spite of this, the patient was still tachypnic, reaching respiratory rate of 70. He was getting more tachypnic. There was a subsequent intervention of intubation and put him on mechanical ventilator. I'm not sure if there was a non-invasive ventilation mode for this patient on Sudan Cardiac Center. I'm not sure actually. As we mentioned, chest tube was inserted. On insertion, it brought 700 ml of bloody effusion, followed by a cirrus. Following this massive amount of blood, he was low hemoglobin of 8 on day 7, for which he was transfused. And actually, they put him on scheduled Lasix, and even started low molecular heparin for him, as managing as pulmonary embolism, with plan to be monitored by bleeding profile every 3 days. and antibiotic was started with third generation cephalosporin ceftriaxone, and then this patient was referred to us in Jaffer ibn Auf PICU.
So let's pause here for a second and just reflect on some of this. There's a lot of information here, and a lot was done for this patient. Any thoughts or questions from the group? Colleagues in Sudan, colleagues outside of Sudan, any questions about the management, any questions about how he looked? Would you consider doing something different? I'm going to go back to Mohammed Al-Amin. What do you think about the PE? There you go. Mohammed Amin. So did they do an ECG?
Actually, it wasn't documented. It wasn't with the patient report, so I think it wasn't available.
Taqwa معلش, CRT, can you tell us the abbreviation, what you mean by CRT?
Which one?
CRT. What about CRT? What do you mean by CRT? Capillary refill time. Got it. What was his capillary refill time?
Oh, okay. It was less than 2 seconds. He was hemodynamically stable. He wasn't on shock or dehydrated.
Nuha, they weren't able to do an echo despite this patient being in a cardiac center.
Yes, actually, the consultant or a fellow of cardio, she tried to do for him, but he was very agitated and not stable at that time.
So I'll start because there's a few things. So what does everybody think about the PE and the well scoring and the D-dimer in this context? Do we follow it? Do we not? Does it mean much to us in pediatrics? Does it not? There is a history of trauma. He had a trauma to his knee recently. Yes. Does it change? Would you still consider it? I'd really appreciate if you can unmute and speak up. As a Sudan. Any thoughts? Khalid, are you still there in the ER? What do you guys do about D-dimers and well scoring? Do you use it in pediatrics? Yeah, exactly, Nuhas. I think that's a big point. It's not validated in pediatrics, so well scores. You can the D-dimer, okay, if it's high, you'll see it high in sepsis, in DIC, you'll see it high in a lot of pediatric, in the context of pediatric illnesses and sepsis and critical illness in pediatrics generally, right? So you can't just go off of D-dimer, just like in adults as well. So it would be hard to just go off of a well score in a pediatric patient and treat based on just that. We don't have an EKG, we don't have a chest and a CT angio or an echo. I think, personally, I would have wanted to get those before I would commit this patient to low molecular weight heparin, especially when they put in a chest tube and evacuated 700 mLs of bloody fluid, right? Somebody commented on the 700 mLs of fluid all at once. Why did you ask that question? There's no name, but whoever owns Al-Indu Hawawi, why 9? You asked about, did they withdraw 700 mLs all at once? Any thoughts about the volume of fluid that we drain? معلش برضو كتبت بالعربي ما دكتور يعقوب, I guess. Is that Dr. Yaqub? Dr. Yaqub, do you want to comment on draining 700 mLs at once, please, if you don't mind unmuting? Okay. The fluid was bloody. It was bloody fluid, 700 mLs of blood was evacuated. All right. And then Hiba, to your point, why did they consider PE as a differential? It is rare in pediatrics. Absolutely. I think that's one of the questions that we had too, is in a pediatric patient that would be on our differential. He has history of trauma, etc. But still it would be a lot lower in our differential. I would probably manage common things being common, like Dr. Khalid was saying earlier, the bread and butter pediatrics first. And even if we did have PE in our differential with blood coming out of the chest tube, I would want to at least make sure that this is managed first before we commit this patient to anticoagulation. Dr. Izzeddin, who's one of our infectious disease consultants here in the US, said, I would consider staph and strep in addition to the Kingella and H flu as possible etiologies, and it would add vancomycin and ceftriaxone. That's a good point. So in Sudan, we do ceftriaxone, but I see we also do all sorts of generation of antibiotics. So, do you want to comment on the antibiotic choices?
Actually, we start the vancomycin choice at PICU just on day one, just on his arrival. Initially blindly, and sepsis screen was taken.
Yeah. I would investigate for bleeding disorders or clotting factor deficiencies, right? And exactly, you make sure if he has 700 mLs of bloody effusion, you have to consider whether there's also a bleeding disorder, or if this patient's coagulopathic, right? Is there some coagulopathy? Should be evacuated. And this is the point, Dr. Yaqub, thank you for bringing it up. You know, when you have this large amount of effusion, evacuating it all at once can actually be more deleterious to the patient, yes, because you run the risk of re-expansion pulmonary edema. And so we try to evacuate this in small increments, unless the patient is unstable and you want to, it has tension physiology, then you want to evacuate as much as you can to hemodynamically stabilize the patient. But otherwise, you want to drain small amounts at a time so the patient doesn't develop re-expansion pulmonary edema. And Nick, do you want to comment on that?
Yeah, you mean like we want to clamp or stop the chest tube on less amount?
Yes. So we,
not such amount or.
Yes, we don't typically drain all 700 mLs. It's very tempting when you put the chest tube in and you see that fluid come out. It is very tempting to just let it all come out. Yes. And again, that could be more problematic for the patient. Okay. There's a risk that the lung that's been collapsed for so long will re-expand and develop pulmonary edema by just physiologic shifts. And so we drain small amounts at a time.
Okay.
There is no magic number. You can read the literature. Some say just do 2 mLs per kilo at a time and then come back and drain some more. Some drain like 100 to 200 mLs, 300 mLs, just to relieve some of the symptoms and then clamp and come back and drain later. Nick, do you have any magic number that you follow?
No, I think it depends on the size of the patient, but I agree. I think being as long as you're not having hemodynamic issues from the pleural effusion that's pressing on the heart and causing blood pressure problems, which this child did not have, then I think being a little bit judicious about how you pull the fluid off. And if they do become hypotensive, thinking about using either FFP or albumin as your replacement fluid early might be helpful. And I agree with all your points about being a little bit cautious about the D-dimer and jumping to a pulmonary embolus as the cause of that elevated D-dimer.
Very good. Dr. Yaqub, do you target a specific number when you're draining the chest tube fluid? Do you have a magic number that you go off of? I generally try to, relieve the symptoms. So drain maybe depends on the patient's size. Anything from 100 to 200 mLs, and then I come back and drain some more later. But if it's a small infant or, toddler, I try to go by maybe around 2 mLs per kilo, nothing more than that. Sometimes I can go up to like 5 or 6 mLs per kilo, but I try to limit. Dr. Yaqub, do you have anything that you want to add to that? It should be over time, yeah. Okay, perfect. Thank you. Okay, do you want to keep going, Safwa, and tell us what you guys did in Ja'far ibn Auf?
Yes, on arrival to Ja'far ibn Auf, he was connected to mechanical ventilator. And first I'm going to start with the respiratory progression. Actually, he started with hypoxic respiratory failure, Then he proceed to both hypoxic and hypercapnic respiratory failure, as we're going to see. Actually, sorry.
You want me to share, or are you okay?
It's okay. I'm going to show a table just to reflect the setting and the APG following this patient. I just put like the significant ABG, not all of them. Starting, we have the first significant ABG on day 4. The patient was on pressure control mode, ventilation. His pulse oximeter showed 98%. He was on FiO2 of 55. In spite of hypoxic index revealed 116. His BIP was 12, and his PEEP was starting with 5, and respiratory time 0.7, respiratory rate 20. At that time, his pH was 7.37, CO2 of 35, PO2 of 64, and bicarb of 19. Actually seen that patient was hypoxic. This raised his FiO2 to 100 and respiratory time to 0.8. Then the patient was improving. On day 11, the patient was on SIMV mode, pressure control. His SpO2 was 100, FiO2 45, and hypoxemic index of 120, BIP was 10, PEEP 5, and respiratory time 1, respiratory rate 20, pH 7.46, CO2 of 28, and his PO2 was 54, and bicarb was 20. Actually, he was getting very hypoxic on this day. Checking his DOP and everything, a chest tube was found to be blocked, and surgery consultation was done, and chest tube needed to be replaced at that day. And FiO2 was increased to 100, respiratory time rise to 1.3. Then pH becomes 7.42, and CO2 was increasing to 40. PO2 improved to 60, and bicarb become 25. So actually, the cause of retaining at that day and being more hypoxic is test tube most properly blocked. On day 16, the patient was on same mood. He was maintaining his pulse oximeter saturation. FiO2 was 70, and hypoxemic index of 127, BIP of 10, PEEP was 7, reaching even to 10, and respiratory time was 0.8, respiratory rate 20. Actually, the ABG on that day was 7.08, CO2 reached 89.7, and PO2 was 89. His bicarb was 26. According to this ABG and severe respiratory acidosis he had, he was given sodium bicarb, and all the DOP was revised, putting in mind he was getting severely ARDS, but unfortunately there was no chest X-ray available, portable X-ray available at that time. Starting to check all the ventilator setting and the size and length of ventilatory circuit, ET tube, looking for our other factor that can cause rise in CO2. That's why FI2 was increased to 100. Hypoxemic index was reaching 20 PEEP up to from 5 starting up to 10 on that day. Respiratory time was 0.7. Respiratory rate was increased to 35. This improves the patient acidic state to 7.34. CO2 was decreased almost to the half. PO2 was unfortunately dropping, and he had the PO2 of 52, and bicarb was becoming to 24. On day 17, he was on the same mood, maintaining a good pulse oximeter saturation. FI2 was maximum, and BIB increased to 24, PEEP reaching up to 10, from 5 to 10 all over the day, and respiratory time 0.8, respiratory rate 17, pH was 7.41, CO2 44, BO2 78, bicarb 25. On day 18, pulse oximeter was showing 99% of oxygen. FiO2 was 60. His hypoxemic index slightly improved to 146, and BIB was 24. PEEP from 5 to 10. Respiratory time was 0.7. His respiratory rate was 17. His pH was 7.07. Again, he was severely acidotic, with a frightening measure of CO2 reading more than 150 CO2, PO2 88, and bicarb was 42. Actually, this was overnight ABG finding, and it was a very frightening. Suddenly he became more than 150. So we start to check all the DOPA again. ET tube was patent, no obstruction. The chest tube was already removed by that day, and chest X-ray was not available, unfortunately. Checking all the DOP. There was a multiple factor for this patient. Actually, the causing of retention could be due to perfusion ventilation mismatch, because at that day he was showing a shock state. He was on shock, actually. We're going to talk later about his hemodynamically state. He was shocked at that day. And regarding the setting, actually, when we decrease the respiratory rate to 17 and put in TI time only 0.7, actually we find that the IE ratio was 1 to 3, and even more, 1 to 3.5 almost. These two factors, in addition to ARDS, could be the cause and the initial pathological condition to reach such a frightening figure for this patient. The intervention was Bryson FI2, trying to increase the minute ventilation for this patient by increasing the PIP to 35, decreasing PEEP from 10 actually to 5. And respiratory time was put 1.3. Respiratory rate was increased to 35. Unfortunately, he was improved by, and even we count the expected bicarb for this patient. Actually, on 2 days that he was retaining CO2, the expected bicarb, for example, on day 18 was 68. That's why we need to give him, or we gave him bicarb. For this, pH becomes 7.20, CO2 82, sorry, BO2 was 93, and bicarb became 29.
So, Safwa, I'm going to ask you to keep going just in the interest of time, because we're getting close to the end of the case presentation. So why don't you keep going, and then we'll open it up for discussion on the different interventions to improve the gas exchange.
Showing, yes, show progress for this patient. This was X-ray on day 1. Actually, sorry, I have a technical issue. Yes, and this the second X-ray was on day 2 because there was a self-extubation on that day, confirming the both chest tube and ET tube position. The third one was on day 15 after chest tube was removed. Regarding sepsis, we had a chart for a temperature chart. The vertical axis showing the temperature, horizontal shows the hospital days on PICU. As the figure is showing that he was hyperparexic all over the admission. Only if he has on day 6, 7, and 10, he was normothermic. Apart from this, he was high temperature and febrile. Regarding day 4, his temperature rise. That's why we request a new CRB, which was rising to 168 from 120 above. Before that, sorry, his white blood cell was 40. The next rising day on temperature was day 18. At that day, he became more septic and he developed more septic shock. He needed more inotropes, and CRB was repeated, but was rising, and even CBC revealed pancytopenia. On day 11, the temperature was rising again, and his CRB was the highest of 170. On day 19, day 12, sorry, he was more septic and temperature was high. On day 17, the CRP was 100. He was pancytopenic, and we're going to discuss the management of his condition. Firstly, he was suspected by osteomyelitis, a source of infection, for which he was put on ceftriaxone, vancomycin, meropenem empirically, and the first result of blood urine culture were negative or showed no growth. On the next rising CRP, actually a pulmonologist put the suspicion of hemorrhagic pneumonia staph aureus, based on the X-ray finding of massive pleural hemorrhage and consolidation, and suggest to start colistin and continue on vancomycin. On next rising CRP and sepsis, on day 8, white blood cell was 6.9, hemoglobin was 8.8, for which he was transfused, and platelet was normal. The source of infection were osteomyelitis. Even by that day, he was malaria positive by blood film for malaria. Actually, ongoing fever was happening. That's why we start an anti-malaria, and we change the antibiotic because he was getting more septic and ill, and he had bed sore, unfortunately. Regarding malaria, we start Quartem, which is artemisinin lymphotrine tabs for him because it was uncomplicated malaria. On the high CRB day, actually ongoing fever, patient was not responding to all this change of antibiotics, and he was getting more sick in spite of starting anti-malaria even. That's why TB workup was done for him. Unfortunately, he showed mycobacterium tuberculosis based on PCR, conventional PCR took from his pleural fluid sample. And ZN stain or acid-fast bacilli was negative, but the conventional PCR was positive. Therefore, starting an intense course for anti-tuberculous, adding to it dexamethasone because it was a pleuritic TB. At that day, even the result of the synovial fluid we mentioned earlier was coming, showing a levofloxacin sensitive coliform microorganism. The rest of admission, there was no significant change on septic workup or plan.
Dr. Safwa, just let's pause for 1 second. There is a few questions about the choice of antimicrobials. Why vanc, meropenem, and ceftriaxone all together, and what was the justification? I'll let you speak to that. I've also asked Dr. Izzeddin, who's one of our infectious disease colleagues, to comment on the choice of antimicrobials. Granted, he works in the US and not in Sudan, so he might not be as familiar with the antimicrobial resistances and trends in Sudan, but I'll still open it up for discussion just briefly for maybe the next 2 minutes. Izzeddin, are you still on? Can't see if he's still on. Yes, there.
Hi, Dalia, can you hear me?
Yes, can hear you. Thank you for joining.
No problem. Yeah, so I think this is a very difficult case. I think to begin with, so the fever is not surprised. I'm not surprised by the persistent fever, because this in itself, if you have pleural effusion or pericardial effusion with the pro-inflammatory cytokines, you can have persistent fever for a while. But given the decompensation in between, I agree with the more workup, and in Sudan you have to rule malaria. But I would I'm not sure if there is any bacterial cultures done on the pleural effusion, or even once intubated to rule out any ventilator associated pneumonia. Any cultures would be done or not, but I'm sure they added the colistin most likely because of the multi-drug resistant, gram negatives in Sudan. Here in the US, we would have started something like cefepime, not Amvanc. But as you said, yeah, the resistant pattern in Sudan could be different. So, and then they did the right thing with would have done the TB from the beginning. His any endemic. In Sudan, TB is very endemic, so I would have done TB PCR, and also you can also use adenosine deaminase, EDA. That's a cheaper test and it's available in Sudan, so we could have done that. If it is high, that will point you to our TB.
Thank you. Thank you very much, Dr. Izzeddin. Very nice. Safwa, I think Dr. Izzeddin and Dr. Safwa were asking if the pleural fluid was sent for analysis or not.
Yes, it was sent to culture and analysis. Only the result of the TB was positive. The PCR for TB.
Okay, thank you. Do you want to keep going with your hemodynamic?
Yes, just there's one point I forgot to mention. Actually, when we start the anti-malaria, we face the problem that is trimethoprim has interaction with anti-malarial medication first, and with Clexane and heparin we started earlier, and even with rifampicin as a part of anti-tuberculous. That's why we withhold the trimethoprim later. Regarding fluid balance of this patient status, I'm going to represent the positive in blue and negative fluid balance in red. Actually, I present all sequence of the fluid balance to compare and see. Fortunately, there was no more positive or more negative all over the admission. He was almost neutral apart from specific days, such as day 2, he was positive 500 And on day 14, he become a positive 1 liter. And the cause was mainly that he developed an AKI with almost an urine output of 0.3. He was on RFT, creatinine was 1.3 and PUN was 36. Going through that, on day 8, he developed shock. On day 10 of negative 578 fluid balance, his urine output was good, almost a borderline of being polyuric. On day 12, in spite of being neutral and minimum positive of 30 ml, his urine output was only 0.7. On day 14, having a positive 600 something ml, his urine output was less than 1. On day 17, he was negative 972. Put in mind his urine output was polyuric range of 4.7. Actually, it could be a sign of getting recovery from AKI because the next RFT was normalized. Regarding his hemodynamically of instability and developing shock, actually he on day 8 he started to having CRB or capillary refill of more than 2. His blood pulse rate was good volume, hypotensive in a term of systemic blood pressure by non-invasive measuring. And in addition, his hemoglobin was 8. That's why we labeled him as warm septic shock, starting noradrenaline, and he need even dopamine. On day 11, he started to develop increasing hepatomegaly, tender hepatomegaly reaching 10 centimeter spleen of 6 centimeter below costal margin and generalized edema. At that time, the echo revealed an ejection fraction. They comment that it was unremarkable of detail of ejection fraction of 75%. There was no pericardial effusion. She comment that there's a mild thick pericardium. An ultrasound was done showing a large liver spleen with normal and mild ascites. That's why we thought about cardiogenic shock in addition to the septic shock, giving him dopamine, NORAD, and even hydrocortisone after consulting the endocrinological department. Going process after day 11.
Question to clarify, Safwa, sorry to interrupt you.
Yes.
The microgram, it's not total microgram, it's microgram per kilo per hour.
Yes, yes.
Okay,
yes.
just so that we can clarify.
Yes.
But this is the doses, yeah, it's pretty high doses.
Actually, we start with low dose, but he need more and more. On day 11, as we mentioned, between day 13, after day 13, actually, he's starting to be needing less inotropes till day 16, where he need a maximum dopamine and even NORAD of 1.5 to maintain his blood pressure. At that day, hemoglobin also was 8. And he needed to be transfused to maintain our target hemoglobin of 10. Showing progress on day 17 and day 18, he started to needing more or maximum inotropes using hydrocortisone. Actually, on day 19, he developed a high-grade fever with face and neck rash, vesicular in nature, associated with cold extremities, small thready pulse, and interestingly, as a central line for him showing a positive aspiration, but we cannot infuse through it. That's why we think about, in addition to septic shock, maybe he developed an anaphylactic shock because of the rash thing. And we concern about the cardiac condition because of ability to aspirate only from the central line. Actually, he needed a maximum 4 inotropes and management of anaphylactic shock in a term of antihistamine and IM adrenaline and hydrocortisone. Next day morning, we consult a cardiologist, and echo was repeated, showing suggestive features of constrictive pericarditis. And their plan was to continue on Lasix and add aldactone for him. And this was an echo report commenting on dilated intravascular, inferior vena cava, with no breathing variation, no pericardial effusion, but a very thick pericardium. This is a summary to the progress of the patient. That he presented first with cough, fever, shortening of breath associated with severe chest pain. On day 4, he started to be more septic with multi-organ failure, respiratory failure, and AKI. Then 4 days later, he became more septic. Malaria was positive. He was pancytopenic, and even blood needed to be transfused for him. On day 11, TB was positive. He needed more inotropes, hydrocortisone, and rising, or the highest CRP for this patient was on that day. On day 16, he became both hypoxic and hypercapnic. He started to retain his CO2, and he became more and more septic and shocked. He needed more inotropes, and he needed to be transfused. On day 18, we had the frightening CO2 figure, and fortunately, AKI was improving and resolved. Day 19, the condition started to be more sick in terms of fever, rash, and maximizing the 4 inotropes, and the pericardium was a very thick pericardium according to echo. And unfortunately, the outcome of this patient was on day 20 of VICU admission. He was on a maximum mechanical ventilator setting, and 4 inotropes, hydrocortisone, Lasix, and aldactone, in addition to antimicrobes. In spite of all this, unfortunately, he developed hypoglycemia and low sodium bicarb. Even he became more anemic. He was transfused, and sodium bicarb was given, and hypoglycemia was managed. At 6 hours later, at 9 p.m., patient was arrested. CRB was done, unfortunately, for 30 minutes. 2 boluses was given of normal saline, and D10 adrenaline, sodium bicarb were given, and this was confirmed. Any question?
There's a few questions in the chat, but I just want to say, Yani, our colleagues in Sudan did everything they can for this patient, given the limitation of resources that they have. They tried their best to help this patient get through all his medical problems, and it was a very complex case, obviously. So just keeping that in mind as we ask questions and as we proceed with the discussion. Did you not have noradrenaline from the beginning? Because we started dopamine. So that was one question. You started dopamine first and not noradrenaline.
No, we start noradrenaline, and we needed dopamine. Actually, we had like an issue of availability of high doses of noradrenaline infusion all over the day. So sometimes we need to adjust this to provide it for the infusion dose or the 24-hour dose, that's why. But we start with noradrenaline. What was the second question, sorry?
What was the treatment for malaria that we used?
Quantum artemether, lamphetrin tabs.
And then another question was why cardiogenic shock and not septic shock? These are great discussions. Do you want to comment on why you were thinking cardiogenic shock and not septic shock at the time?
Actually, at time of the day 8, we think about septic shock mainly, but due to the progress of patient in spite of maximum antimicrobes and changing antimicrobes, and he started to develop symptoms of cardiogenic shock such as low systolic pressure mainly, and that's why we concern cardiac shock. And he presented with right side heart failure symptoms in the term of tender liver hepatomegaly, spleen was 6 centimeter below costal margin, and generalized edema. That's why we thought of heart failure. And actually, we were thinking about both septic, and on the top of it, he developed a cardiac failure or a cardiogenic shock.
And remember, they're not mutually exclusive, right? So you can develop sepsis-associated cardiac dysfunction. So not mutually exclusive.
Sepsis can even affect the heart itself. Yeah.
What about fungal infections? So Haifa, we'll get to that question. I'd just like to ask my colleague Mohammed Sadiq to comment. He's had his hand raised. Mohammed, welcome. Very nice to have you.
Yeah, assalamu alaikum, Dalia. Good evening. Nice to meet you, people. First of all, I want to thank you. Keep me safe. Safwa, shukran. Thank you for this nice case. I think you demonstrate the struggling of the people here in Sudan when they deal with cases which need advanced intensive care support and therapy. It is obvious this child was struggling from the start, from the ER till he get the referral to an ICU, and for sure it was obvious that the ICU management, although the people they do their best, there was a lot of lacking point in the ventilation, in management of shock. And just I want to highlight that most of these patients and most of our patients in Sudan, they are managed with the people with interest in the intensive care. Most of the cases, most of our ICU still not leaded by intensivists. So I believe that the people in Gaffer and Ma'ouf, they do their best with the minimum support from the senior colleague. They try their best to diagnose, and they have this issue of limited resources. There is no X-ray, difficulty to get blood gases, delayed consultations, inavailability of other pediatrics subspecialty like infectious diseases. They get the consultation delayed. It's obvious that in this case, the ventilation management was not appropriate. So the respiratory or ARDS strategies was not followed. I just want to thank people what they are doing. They are doing their best. But I think this should open the floor for all of us to think what we can do to help these young people in their ICUs. And I think what we are doing now is going in this track. I believe that we are still lacking in the ER and intensive care pediatric services, and there is a huge work should be done to make it better for our children. Thank you so much.
Thank you, Mohammed. Appreciate your words. And absolutely agree. They've tried their best with the resources that they have. I think they've done everything. And it doesn't help that this patient is extremely complex. It's layer after layer after layer. Nick and I were talking about this also, like if this patient had also landed here in the US, how complicated this patient is. So can only imagine how difficult this would have been in Sudan. So, and to Mohammed's point, it opens the door for discussion on how we can, we can all take a minute to think about how we can help our colleagues in Sudan whenever they're faced with cases like these. And, even if it's education and helping them through like this, just to think through a case like this and how to manage it next time that they're faced with it. So I'd like to open the floor maybe for the next 3 minutes for discussion for those in the group, if they have questions or if they have points or, you know, teaching points to bring up, other ways of doing things, other points to think about in this case, or if they're faced with this case next time, before we hand it over to Dr. Hashim to talk briefly about pericarditis and for Nick to talk about delirium. Okay, I'm gonna read Isra's point, unfortunate child, huge effort, just asking about choosing Quartum in such an ill child in the PICU. Should you start with quinine in such a sick child? Safwa, do you want to comment on why we chose?
Actually, thinking to start a management of a complicated malaria starting with quinine, but the infectious consultant was advised it's not her. She advised us to start with Quartum, and actually when we repeat the BF 1 day after, it becomes negative, so she questions the reliability of the result and if we can manage it as a severe malaria, not a simple malaria. That was advised by infectious consultant.
Thank you. Okay, Dr. Malka, do you want to unmute and state your question or comment?
Hi, my question was, I think it was day 16 in the ICU. Why did the patient suddenly become acidotic? Was that the blocked chest tube? He developed, I think it was type 2 respiratory failure. Was that because of the blocked chest tube?
Actually, no, the chest tube was removed on day 15 and the lung field was okay. He didn't develop a cumulative effusion again after that. Even by auscultation, there was no dullness, nothing suggesting an effusion again.
I think if you go back to the ventilator settings, I think on day 16, it shows that I think the pH was 7.06, 7.04, something like that.
It was 73445 CO2 with a PaO2 of 52 on day 16. The one before it, yes. The one before it was 70889.
Yes.
Yeah. So I just wanted to know, because before, what was the cause of the sudden increase in the PCO2? So what was the cause of the type 2 respiratory failure on day 16?
Actually, we was thinking about ARDS, getting more severe ARDS, but on that day, chest X-ray was not available. And in addition to, he had a ventilation perfusion mismatch. And
okay. Thank you. Thank you very much.
Welcome.
Izzeddin, go ahead.
Hi, Dalia. The only thing is I would to add is just keep in mind with TB itself, it can cause also, beside that, pericarditis, myocarditis itself. So could all this be along just a TB? That's possible. And then the other thing also, whenever we diagnose a child with TB, we need to look for the source. So hopefully they have screened all his family to make sure there is no one. Usually an adult will have the disease and infect the child. So they should be all screened for TB too.
Yes, this is yes, it's a very important point. We will mention later on communication with family. They were as advised to be screened, and I'm going to mention, but there's as we are here again on APD, I wanted to mention it on challenging slide, but I'm going to mention it here. Actually, one of the challenges that we couldn't raise PEEP more than 10, 12 for this patient, in spite of being more hypoxic and ARDS, that he was a very difficult patient to sedate, and this patient, in spite of giving all the maximum sedation we had, and he had a history of removing or self-extubating himself twice. He chest tube, he tried to remove it, and it was blocked. So we really couldn't. This is one of the most challenging points, that we couldn't sedate him to the point that we can raise PEEP and the setting to improve and manage him as proper ARDS.
Thank you, Safwa, for bringing that. And I think just to comment too.
We reach for this patient was 10, 12 maximum on flow sheet of nurse, but more than that, we couldn't trace it because he was really difficult to sedate.
Yes, and this is to go to Dr. Melka's point, is the respiratory failure in this patient is likely multifactorial. I think we can say it's ARDS and worsening parenchymal disease. You can see that the AA gradient's getting worse. I think there's a lot of patient ventilator dyssynchrony that we're going to talk about, which is one of the main points we were going to bring up today on this discussion. Is this patient self-extubated several times, so it was clearly not very well sedated. And I think that added to the worsening respiratory failure and their inability to adequately sedate and manage the vent. The other thing is airway clearance is another thing, right? Going through all the dope pneumonic, they tried their best with the resources that they have, but that also factored in. So we're going to pause here because we have our speakers would have a few slides to bring and share with us. So we'll have Dr. Hashim present on constrictive pericarditis briefly, and then from there Nick will talk about delirium, which is one of the main things that the team had struggled with in this patient who ended up self-extubating several times, which obviously would not be ideal for a patient with such a complex history. So Dr. Hashim, are you still there?
Yes.
All right, you ready to take over?
Yeah, sure.
All right.
Okay, so thanks for having me today, for inviting me to come to this meeting. As Dalia mentioned at the beginning, I am an adult cardiologist, but one of the reasons I've agreed to participate in this is because constrictive pericarditis is very rare in pediatrics. It's rare anyway in adults as well, but I think we see much more in adults compared to pediatrics. There are a few points I want to make before I start talking about constrictive pericarditis. The first one is, I know it's a repeat, but it's important. The fact that when the patient presented, there was suspicion of pulmonary embolism, and a chest X-ray was done, which showed a large or pleural effusion. I think there was no need to suspect pulmonary embolism because you already have a diagnosis that explains the presentation. The D-dimer is not massively raised, and even in adults, I know you've mentioned from a pediatrics point of view, it's not common to talk about pulmonary embolism, but even in an adult, if there was PE, let's just, I doubt very much that there was PE here, but if there was PE, there's a big decision to make about whether to give anticoagulation in a patient who had a major bleed that required blood transfusion, and it has a hemorrhagic pleural effusion, which the main reason is it will keep draining blood into the pleural space again and again. And I think probably from what I've heard from the presentation, it may have not affected his outcome anyway, but I think that's something definitely that needs to be reflected on and for future cases. The second major point I want to make is that, yes, constrictive pericarditis was mentioned, and I have not seen the echo images myself, but from what I've seen, I would classify this as a suspected constrictive pericarditis rather than a definite, and it may have contributed to the outcome death, but I don't think it should be high on the list on the death certificate. And the reasons why I'm going to explain while I'm presenting. I'll try to be very brief because I think overall, in this case, it's a minor issue, the constrictive pericarditis. So the first thing I want to clarify is that when we talk about constrictive pericarditis, we're not talking about acute pericarditis, and we're not talking about pericardial effusion or tamponade. So this has to be clear from the outset. So acute pericarditis, someone has a viral infection, for example, and gets chest pain and breathlessness, and the pain characteristically gets better when you lean forward. This is the acute inflammation of the pericardium, and it's called acute pericarditis. You can get a bit of effusion with it as well, but this is something different than constrictive pericarditis, which usually happen later. So after weeks of inflammation, usually, for different reasons, or other types of injury to the pericardium, you get scarring of the pericardium, and rarely you get effusions. Usually you don't get effusions because of the scarring. There's no pericardial space as well. So that's different. It's not acute pericarditis. And the second thing, it's not it's different than pericardial effusion or tamponade, when for different reasons you get big effusion in the pericardium, or rapidly filling effusion that compresses the heart and causes problems. And although the compression of the heart causes similar problems as constrictive pericarditis, but again, it's different. And you've noticed in this case, there was no pericardial effusion. Or at least it wasn't reported or mentioned. So constrictive pericarditis can occur following any pericardial disease or injury. So post-cardiac surgery in adults, post-infection, or any other different reasons. I'll go through them in a minute. But any disease that affects the pericardium can eventually lead to constrictive pericarditis. It's more common after bacterial or tuberculous, especially in the developing countries. The time between inflammation and constriction is variable, so you can't exclude it just because it happened 3 or 4 weeks ago. You need a subacute or chronic inflammation. If you get pericarditis, it's unlikely that next week you'll develop constrictive pericarditis, but it can happen. It's rare, but it can happen. But there's no time frame that you can say that this is when you can develop constrictive pericarditis, but usually weeks and months after pericardial injury. The common causes, this list reflects the Western causes more than in developing countries. I'll definitely put tuberculosis as one of much higher on the list if it's in the developing countries. So idiopathic viral post-radiation therapy. So in adults, mainly post-radiation therapy. Sometimes if you have a cardiac surgery and you can develop constrictive pericarditis because of scarring after the operation, some connective tissue disease, tuberculosis or bacterial pericarditis. And there are many other causes, malignancy, trauma, drug-induced uremic sarcoidosis, and other diseases. So the main problem with constrictive pericarditis is that the pericardium, which is the sac surrounding the heart, becomes stiff. So it's usually elastic, and when the heart relaxes in diastole, so it allows the heart to relax. But when it's stiff because of scarring and it does not allow the ventricles, the right and left, to relax, because when they're trying to relax to start filling the ventricle, it hits the heart pericardium, and it doesn't affect. The right ventricle is affected more, and the reason is that the left ventricle muscle is thick and much stronger, whereas the right ventricle muscle is much thinner, and so the pericardium fluid or constrictive pericarditis can press on the right ventricle much easier, and that's why you get the right heart failure. So usually a classic constrictive pericarditis case would not have high temperature like this case, would present with gradual onset of right-sided heart failure. So the patient presents with right heart failure, and you think it's right heart failure, and you start to look for causes for that. So fatigue, breathlessness, edema, abdominal swelling, and symptoms and signs including general congestion, pleural effusion, hepatomegaly ascites, which this patient had. One important sign, not 100% of the cases, but is the Kussmaul sign. I think with lack of time, I'll just rather than ask, I'll just explain. It's increased. So the JBP is raised. It was raised in this case, but one way of thinking about constrictive pericarditis is to see if when the patient takes inspiration, or you ask the patient to take a deep breath in, or during inspiration, does the JVP get worse, which is opposite to what happened usually. So usually when you do inspiration, there is negative pressure in the chest, so the JVP drops, but the opposite happens. And the reason why it happens is that because even though the negative pressure sucks a lot of blood back to the right ventricle can't accommodate it because of the restriction, because of the pericardium, constrictive pericarditis. So in fact, because of suction of blood, more blood, then it goes up. So it's this is one of the signs that you can look for. So to get a diagnosis of constrictive pericarditis, you need signs and symptoms and signs of right-sided heart failure, plus evidence of diastolic filling impairment. And this, you can get it with echo, and you can, if the patient is stable, you can do CT or cardiac MRI if available. And sometimes if there is diagnostic doubt, you need to go ahead and do a cardiac catheterization. And it's rarely needed, but it's more diagnostic. Investigations. So, you know, in cardiology, ECG, chest X-ray, echo, you won't go wrong if you do those. But yes, there are changes on all these tests. I'll not talk a lot about CT or cardiac MRI because I don't think it's commonly used in Sudan. I'll touch a bit with the cardiac catheterization. So ECG, so as I said at the beginning, acute pericarditis, you get the chest pain, breathlessness, and you get ST elevation, saddle shaped, all these. This is not what you find in constrictive pericarditis because it's a chronic condition. And in fact, what happens is because of the movement is less and the stiff pericardium, you get small complexes. So it's not a perfect ECG, but yeah, you can argue that the complexes here are smaller than usual. I've had a look at the chest X-ray on the presentation that Safwa presented. I couldn't see any definite calcifications, but on this chest X-ray here, if you can see on the left border of the heart, it's a bit brighter. You can see actually the around 2 to 3 o'clock of the heart. You can see, or 3 to 4. You can see the it's a bit bright there, and this indicates some that there's calcium there. So the calcified pericardium. This is one of the first signs you can make you suspect constrictive pericarditis. This is obviously one ideal chest X-ray. Most calcifications, you don't see them that clearly, but if you look carefully, you might see some. Echo. So one of the things I was asked to talk about today is how can a non-cardiologist who can do a bit of echo, what can they do to if they suspect constrictive pericarditis and what they can see? So there are a few things. I mean, there are several complicated things that make you come to a conclusion that this is a constrictive pericarditis. There's no one thing that definitely says that this is constrictive pericarditis. So the answer to that is to how you can detect it. It's difficult, but you can pick up. I'll focus on 3 signs that may make you at least make a cardiologist come and see and give you your opinion. So on this slide, the first one, in A, you just see a right because of the congestion and the pressure on the right ventricles, because of as I said, it's easier to press on the right compared to the left because the right is weaker. So the right atrium is dilated. It's bigger than even the left atrium here, I think, is a bit dilated, but the right atrium is dilated. On B, you can see those who are familiar with echoes, you can see the inferior vena cava, which is not collapsing as usual. There's a bit of collapse, but not collapsing. So there's another sign of congestion. So this hints towards there's a problem there, but not specific for constrictive pericarditis. This third sign is a bit complicated, but I'm going to explain it because some people will have some experience in this. So, so when you're doing an echo, let's say in apical 4-chamber view, you put the cursor on the mitral valve, and you measure the in M mode, you measure the or Doppler, you do a the flow in the mitral valve across the mitral valve, and you can see here at the left bottom that first of all the E is bigger than A, which is the reverse. Again, signs are one of the signs that hints towards constrictive pericarditis. And the other thing is that on the first one, there's 50 centimeters per second there, which is the flow measurement. And then on the third reading is 25. So when the patient takes inspiration, there's a significant change in the flow in the mitral valve. And again, this is because of the pressures when on inspiration increasing and the restriction getting worse. So more than 20 is significant. So it's a complicated echo thing, but I think those who do echoes will know that this is one of the important signs, and if you get this, then there's definitely some form of constriction or pressure on the right ventricle or left or the heart generally. One of the characteristic signs of constrictive pericarditis, and I think that would be the one that, in addition to looking for pericardial thickening, that for a non-cardiologist to look for. Normally, as I said, the left ventricle is stronger, so the septum, so the wall between the left ventricle and right ventricle on the left here, usually it's slightly going towards the right ventricle. And with some other pathologies in the middle, you can see that sometimes it's flattened. But in constrictive pericarditis, because there's pressure on the right ventricle from the pericardium, and there's filling pressure, and especially in inspiration, when there's lots of fluid coming to the blood coming back to the right ventricle, there's what we call the septal bounce. So the septum goes towards the LV, which is unusual because the LV pressures usually are much higher than the right ventricle. And but now you can see what we call the septal bounce, which is the right with the septum going towards the left ventricle. So this is one sign. You can do it in 4-chamber apical view. I'm not going to go through all of these, but just to tell you how complicated and an experienced echocardiographer can look for all these things that can hint towards constrictive pericarditis and come to the conclusion. It's not very simple. This is, I'm going to skip this. It's a right heart catheter measuring the systole and diastole pressure in the right and left ventricle, and demonstrate how it's the pressures are equal in diastole. Last thing, or just thing for last, is the management. So if this was a constrictive pericarditis in this patient, and if he survived the sepsis, the pleural effusion, the osteomyelitis, the malaria, and everything else, and the problem became congestion because of right heart failure because of constrictive pericarditis secondary to tuberculosis, then I think initially it's reasonable to give him antituberculous treatment and see if that helps. And sometimes it can reverse the constriction, or at least reduce it. But for other types of constrictive pericarditis, the mainstay of the only way of treating the problem, which is surgery, which is stripping out the pericardium because there's no other solution. Some other causes might respond to anti-inflammatory drugs, so like steroids or non-steroidals in adults as well. This patient was given antituberculous and was given dexamethasone, so I think those were covered. But most of the time, you end up needing surgery anyway, and it's not an easy surgery. The mortality would be 5 to 10% at least, so it's not something easy. And obviously, you need to treat the congestion that happens, but you have to be careful because if you can reduce the cardiac output by getting rid of the fluid without getting rid of too much fluid with diuretics. So you have to be careful sometimes. So giving a lot of diuretics in a patient with constrictive pericarditis may not help, may make things worse sometimes. And in this case, if this patient did have constrictive pericarditis, and you think there's an element of heart contributing to the shock, I think inotropes may not help, because no matter what you give to make the heart contract harder, because it's not actually not opening to fill with blood, then it's, no matter how hard, it can't contract hard. So there's a mechanical blockage of the function of the heart that you will not be able to fix with inotropes. I very much doubt that this was the case in this patient. I think there's other reasons why he had the shock, but it's a problem with constrictive pericarditis, especially at later stages.
Dr. Hashim, I apologize, but I'm gonna have to pause you here so that we can go over to our discussion on delirium as well.
Okay, yeah, that's fine. I'm done anyway.
Okay, thank you very much for your presentation. Nick, you ready? We'll try to go through delirium and sedation, and if we have a few minutes, we'll open up the floor for a discussion. I'm sure there's so many points that everybody wants to discuss here, so.
All right, can we see the correct thing?
Yes.
Well, good morning, good afternoon, good evening to everybody. Thank you very much for having me here. I'm very honored to be here. And as Dalia said, I'm a pediatric intensivist here at Texas Children's, working with her. And I agree, this was really a challenging case that I think we would have struggled to take care of this child here at Texas Children's with. Obviously, we're very lucky to have a lot more resources. And I think the team in Sudan really did a tremendous job and worked very, very hard to take care of a very sick patient. One of the issues that was brought up was the question of self-extubation and sedation for this child. And so Dalia asked me to talk about delirium because I think this session had an earlier session on sedation a couple of months ago. So I'm going to try not to duplicate anything that they may have talked about in that previous session. The goal for today is to talk about a best practices framework for thinking about pediatric ICU delirium. And then also kind of connected to that, I wanted to give you a best practices framework for thinking about iatrogenic withdrawal and also extubation readiness. So what we know about sedation and delirium and withdrawal, a lot of it originally is derived from the adult world. There's a very well-established framework in the adult ICU world, the ABCDF framework, which we have translated to pediatrics. We don't have quite the same evidence base that the adults do, but there's a lot of elements that are very similar. And I put on here two websites, which are very good educational websites that have pediatric specific content. That's, if you're interested in learning more about delirium and sedation, those are great resources to go to with really best current evidence. And then a couple publications down below is sort of summarize where things are in the adult world. But this ABCDF framework is the same framework that we've borrowed in the pediatric world. This is the most recent publication from earlier in 2022, the latest update from the ICU Liberation Group on pain and sedation and delirium. I'm not going to go through the details of this. This is a big publication. And just trying to distill it down, that whole publication kind of distills down to these main points. We're going to focus on the delirium and withdrawal pieces. So for delirium, the summary is to use a validated instrument to assess for pediatric delirium in all ICU patients. The two big sets of tools that are out there to assess for delirium are the CAPD tool and then the PCAM and PSCAM tool. And then for withdrawal, iatrogenic withdrawal, thinking about treating for withdrawal after a patient has been on at least 5 days of continuous infusion, definitely treating. I would treat a patient after about 7 days of being on continuous infusions, and then using the WAT1 tool as the main tool that's been validated in pediatric ICU world to guide your withdrawal assessment and weaning of those medications. So just another publication that kind of gives a nice reframing those same points in a slightly different way. There's a number of tools to look for to guide your management of analgesia and pain. There's basically two sets of tools that are used primarily for sedation, and then two sets of tools that are used for delirium as well. And then the WAT1 tool is the main one that's out there for withdrawal in pediatric patients. Neonatal patients is a little bit different. I include this as well, just a table of typical sedation medications. I'm not going to go through this in detail. I'll send a PDF version of this talk to Dalia, and then she can distribute it to the group, but this will be in there, but just to have a sense of some pharmacologic data on some of the common sedation medicines that we use in the ICU. So what is delirium? Delirium is a behavioral manifestation of acute global brain dysfunction. The brain is not working at a global level, and it's very common. It typically manifests with inattention and confusion, sometimes agitation. And in pediatrics, there's three types that are recognized: hyperactive delirium, which historically was called ICU psychosis. This is the patient that we all recognize. And really, I think this was probably what this patient was experiencing over the course of their stay in the ICU. They were agitated, they were restless, they were pulling at things, they were pulling out the ET tube, they were pulling out chest tubes. This is the patient that we easily recognize and struggle to take care of. There's also hypoactive delirium. So this is the patient who's less responsive than they should be. If we think about it, a young child, a 2-year-old child who's intubated in the ICU, is not normal for them to be still and not moving and calm with a big piece of plastic down their throat. But most of the time for nurses and for physicians, when we see that nice, calm patient, we think, aren't they nice and calm? Isn't that perfect? Probably that's not really what they should be either. And so probably we miss a lot of these hypoactive delirium patients. And I think a lot of patients have a mixed phenotype where they have some days where they're very agitated, other days when they're hypoactive, or other times of day where they're hypoactive. How common is pediatric delirium? The short answer is it's quite common. So this was an international point prevalence study that was published in 2017 across a number of countries, looking at almost 1,000 children using the CAPD tool to estimate the number of delirious patients in their ICUs, and it was about 25% across all these countries. When a more recent paper that compiled a bunch of different papers together found that about 1/3 of all PICU admissions, so this is both intubated patients and non-intubated patients, all patients who come through the ICU in multiple different ICU settings, had delirium. What were the things that were associated with delirium? We'll talk about this a little bit more, but the more amount of benzodiazepine medicine you get, that's associated with a higher chance of developing delirium. The more opioid pain medicines you get, that's associated with higher rates of delirium. More classes of sedations, that's associated. Deeper sedation, and then unfortunately for our cardiac ICU colleagues, going through cardiac surgery and bypass also increases your risk for delirium. Who is at risk for delirium? Who are the most common patients who get delirium? This is also pretty well established. So the different graphs here are different categories along the x-axis, and then the y-axis is percent of patients with delirium. So as you can see, patients who are in the preschool years, 2 to 5-year-old, they're the highest age group to get delirium. Patients who are on mechanical ventilation, the more oxygen support you need, the more likely you are to have delirium. Patients who have a not normal neurologic development, who are delayed, they are more likely to get delirium. And then this was looking at patients who are using the RASS scale instead of the SBS scale, but the deeper your sedation is, the more at risk you are to develop delirium as well. So are there any modifiable risk factors? Are there things that we as ICU doctors can do to help prevent our patients getting delirium? And the answer is yes, there is. And one of the most important things that was well established in the adult world and took a little bit longer to be established in the pediatric world is exposure to benzodiazepines. So the graph here is amount of benzodiazepines across the x-axis, and then the y-axis is the chance that the patient on the next day would have delirium. And you can see that the higher the higher your amount of benzodiazepine is across the x-axis, the more likely you are to develop delirium. And this was a retrospective study of almost 600 patients. And this has been validated in several other populations. So how do we manage delirium? This is a really nice figure that I think it really crystallizes the best framework for how to think about delirium. First of all, if you think a patient is getting delirium and is delirious, is there some underlying medical trigger? Is there an infection? Is the patient hypoxic? Are they actually just struggling to get enough oxygen? Is there some undetected electrolyte or metabolic disorder? Is pain adequately controlled? A great example of this first category was I had a patient about 2 months ago who was an oncology patient who was getting their leukemia treatment on the floor and then suddenly became altered, had altered mental status, became encephalopathic, and had a seizure and came to the ICU. Had a head CT, was put on EEG, all this screening. And then about 24 hours after they arrived in the ICU because of their altered mental status, their blood culture, because they'd had a fever and they'd gotten a blood culture the day before, their blood culture popped positive for Pseudomonas. And so we treated the Pseudomonas, and then over the course of 2, 3, 4 days, the patient's mental status came completely back to normal from being very encephalopathic and confused and upset and crying and not knowing who she was and not knowing who her mother was. And but it was really her acute encephalopathy was really the first sign that she had a new bloodstream infection, a new sepsis. And so that's that thought process is really important. So is this patient's delirium really just a manifestation of something else that's going on that I need to look systematically for? Do they have an infection? Do they have electrolyte problems? Is their pain adequately being controlled? The middle category, are there any iatrogenic factors that can be modified? Are there medications that we can take away? Anticholinergic medications are a big offender here, things like Benadryl. Is the patient over-sedated? Oftentimes we see a delirious, agitated patient, we think, that person needs more drugs to calm down. Well, actually, they might do better with less medication. They might calm down by giving them, their brain might be calmer if you give them less medication. So trying to do that as best you can. Has this patient been in restraints? Can you remove those restraints and still safely take care of the patient? And then I think the last one is also really super important. Can we modify the environment? And here, the big piece is sleep. Making sure that the patient has good daylight. The light is on, there's stimulation, there's noise, there's cares during the daytime. And then at nighttime, the lights are off. There's less stimulation, trying to cluster the care of the patient so that their sleep is not being interrupted during the nighttime. Are we minimizing interruptions? Super, super, super important. We struggle with this here at Texas Children's. Every day that I'm on rounds, I have to talk to families and bedside nurses and patients and say, look, it's 9 o'clock, we're turning on the lights, it's daytime, or alternately, it's when I'm on call at nighttime, it's 10 p.m., it's 11 p.m., turn off the TV, let's go to bed. We need to have quiet and some good sleep. Related to that, and this is challenging in different ICUs where they may not have, depending on how liberal your hospital is with allowing families at the bedside, does the patient have daily interactions with family and friends? Are the parents there with them? Are they talking to the patient during the daytime? Not at nighttime so much because you want them to sleep, but during the daytime, are they interacting with them? Are they giving them healthy, normal stimulation during the day? And then allowing them to sleep at nighttime. If the patient wears glasses, putting their glasses on so that they can see, trying to allow them to communicate, giving them some sort of paper so they can write and communicate their words to you. And then we'll talk about this more in a second, but have they been mobilized and exercised as much as possible? So using you taking advantage of your therapists to help you mobilize patients as much as you can, exercising them while they're in the bed, while they have a breathing tube in, and I'll show you some examples of this in a moment. But this is a really important slide with the sort of conceptual framework of how to think about the approach to delirium. The last thing to think about is medications. After you've done all these other things, potentially you can add atypical antipsychotics as an adjunct to help with keeping patients calm and safe with a breathing tube in place. This is not, the evidence for this is pretty weak. It's been tested a lot in adults and really doesn't, but there are patients where this can help. And then as soon as the patient's extubated, getting those atypical antipsychotic drugs off as soon as possible after they're extubated. Another framework that was published a little bit earlier to help you think about delirium is the brain maps framework. So if you look down the left-hand side, it spells out brain maps, and it's sort of a mnemonic to think about different things. So B, bring oxygen. R, reduce the deliriogenic drugs. A, the atmosphere. Is the family there? Do they have a regular schedule? Are they getting interaction? I, is there a new infection? Do they have a positive blood culture? Do I need to think about infection? Is there some inflammatory thing that's triggering them and making their brain not work? Is there new organ dysfunction, et cetera? A being the big one, a sleep and sleep-wake cycle. So I talked about mobilization. There's a great program from Johns Hopkins University, and Sapta Kudachar, one of our leaders in our field, with a protocol called PICU Up, which is, I put the website down the bottom. So this is a early mobility protocol for all patients, where they to help you assess, is this patient ready for doing exercises and mobilization, and what's the safest thing to do for different levels of patients, different levels of critical illness. But this is really super important. And her phrase that Sapna always says is, illness does not mean stillness. I'm not sure how you would translate that to Arabic, but in English, that's a nice phrase. I included this as well. These are the sort of pharmacologic recommendations for different atypical antipsychotics. If you're going to use them, we typically are using risperidone or olanzapine in our hospital because that's what we have on our formulary. But I just include this for information's sake. The next chunk of that I wanted to talk about was extubation readiness, since this patient did have problems with extubation. This was actually from a very recently published publication from the Policy Investigations Group of sort of best practices, best evidence for an extubation readiness. How do you assess patients? So just going through this a little bit. When clinically you think the patient is within 12 to 24 hours of extubation, checking for an air leak around the ET tube. And then if that air leak pressure is greater than 25, or if you think for whatever reason, based on the patient's history or anatomy, they're very high risk to have upper airway obstruction, thinking about some steroids, we typically will do 0.5 per kilo of dexamethasone for 4 doses with a maximum of about 6 to 8 milligrams, depending on body size. And then screening them for, are they really ready to have a extubation readiness trial? The evidence is not established whether doing CPAP alone or doing CPAP plus pressure support is the best way to do a spontaneous breathing trial. Everybody does it a little bit different. And also, how long should one do that for? The recommendations currently are somewhere between a half an hour up to 2 hours. And assessing, while you're doing that spontaneous breathing trial, do they become tachycardic? Do they become tachypnic? Do they desaturate? Is their Pmax appropriate? And really, there's sort of 2 pieces to this extubation readiness trial. There's the sort of lung and muscles portion, which is how you set the ventilator and how you assess their response to that. But then also thinking about their brain. Do they have a cough? Do they have control of their secretions? Are they awake enough in order to breathe without the ET tube in place? Do they need a sedation wean first? So thinking about both the lung portion of it and the brain portion of it. And then once you've done your extubation readiness trial, if they pass, then thinking about what are you going to need to support them after extubation. If they're going to be high risk, thinking about extubating directly to something like CPAP or BiPAP or high flow settings. Otherwise, going straight to something like regular nasal cannula. For young children, thinking hard about going straight to bubble CPAP instead of trying high flow nasal cannula first due to their muscular tone and compliant skeleton. If they fail their extubation readiness test, thinking about, did they fail more from a sort of cardiopulmonary point of view? Do they need just a little more airway clearance and a little more help with secretions, et cetera? Or was it really more of a brain problem? Were they just too sleepy and they didn't wake up? This is a very common issue in neurologically atypical patients where they need a slightly higher PCO2, end-tidal CO2 to stimulate their brain to breathe. So you sort of have to really wean down the ventilator first, make sure they're spontaneously breathing on a typical mode before you switch them into a CPAP mode. And then retrying another extubation trial in 12 to 24 hours when you think they're ready. So this is just published, the most current up-to-date summary of best evidence for extubation readiness trials. And then the last piece to think about is iatrogenic withdrawal, because this can contribute to delirium as well. So again, when you're coming off sedation, thinking about treating for withdrawal after about 5 days of drips, definitely treating after about 7 days, and then using the WAT1 tool as your validated withdrawal tool to guide your treatment. So the tool itself looks like this. It's a series of questions that have yes/no answers. When do you get the WAT1? You do it every 4 hours as they're transitioning off their continuous sedation medicines, and as you're weaning your iatrogenic withdrawal medicines. What's your goal? Your goal is to get a score of 3 or less. The cutoff of 3 comes from, if you look at the first 3 parts of the criteria, fever, loose stools, and vomiting. Well, that could be gastroenteritis and not withdrawal. So you need to have at least a score higher than 3 to think about withdrawal. If your score is greater than 3, the point is think about withdrawal. It may not be withdrawal. It may be something else, but you should think about withdrawal and either giving extra PRN iatrogenic withdrawal agents, the lorazepam or morphine is what we're typically using, or depending on how high the score is. And so who is at risk to get iatrogenic withdrawal? This is kind of similar to who is at risk to get delirium. This was a publication that came out of the RESTORE trial data. Young children, less than 6 months, have a higher risk of developing withdrawal. Those children who are neurologically atypical at baseline, cognitive impairment, they have a higher risk of withdrawal. Children who've had more classes of medicines, those are higher risk to withdrawal. And then this is relevant both at Texas Children's and also in Sudan. Patients who have whose nurses are taking care of more than one patient, those children are at higher risk of withdrawal. If you have one-to-one nursing, that's associated with less chance of having withdrawal. But we often don't have one-to-one nursing even here. And I know that's the case, definitely the case in other institutions. So why do we care about this? Why is this important? So increasingly, we are recognizing that going through the pediatric ICU really affects multiple domains of health: physical, cognitive, emotional, social, and that children who come through the ICU, even if they survive their illness, come out the other end and potentially are not the same child on the other end due to their ICU experience. And sedation and withdrawal and delirium are a really important piece of that because that affects their brain. So just to give you a couple good examples of complex patients who we were really pleased with how we were able to handle their withdrawal. This was a girl who had a very large, severe Benadryl ingestion, became quite ill with shock, ARDS, AKI. This was about a month into her hospitalization. So this is her sitting up at the bedside, working with 2 of our physical therapists with a breathing tube in place. So a big plastic tube down her throat, wide awake, able to communicate, but still working on rehabilitation with a breathing tube in place. And then this video here was a patient we had in the pediatric ICU who was there for quite a long time. He had a large mediastinal tumor that had eroded into his airway, and so was intubated for quite a long time, getting repair, sort of repair of his airway. And this was him walking with the crew in the first floor of our ICU tower. going for a trip outside with his respiratory therapist, with his nurse, and you can see there's lots of people helping him. So this was kind of our ideal of where we want patients to be: awake, alert, have a big piece of plastic down their throat, but able to interact with nursing and therapists to help improve their recovery. So thank you very much for having me today. It was great to hear about this case. This was a really challenging case. Again, I really want to congratulate all the hard work that the team in Sudan did to try and save this child. And it was a very unfortunate outcome, but I think this was a really hard case. My contact details are down below, and then the QR code on the right is just if people have time and can, a little evaluation of my delirium lecture. But thank you very much.
Thank you very, very much, Nick. Appreciate the presentation. We would also appreciate if you guys can fill out the QR code for Nick. A few questions came into the chat, and then, we're kind of short on time, but for those who have any pressing questions, we'd be happy to stay behind and discuss. But one question that came up, Nick, was, is there any role for clonazepam in delirium? I tried to touch on it a little bit in that we don't typically use clonazepam. We prefer to use the antipsychotics like risperidone or quetiapine when our non-pharmacologic methods have failed. Do you want to add to that?
Yeah, I mean, I would be, clonazepam is a benzodiazepine, right? So that's the class of drugs that is most associated with being deliriogenic. So I wouldn't say it's a contraindication, but I would be very cautious about it, that it could make things worse, depending on what other things the patient is on. I realize, drug availability in resource limited settings is a real major issue, and you have to work with what you have to work with. But I wouldn't be my first choice, I guess would be the best way I would phrase it. I would be very careful about it. It might, go ahead. Sorry.
I was just going to say, another question that came up, Nick, which I think is a great question, is can you think of any non-pharmacological delirium bundles to be used in resource limited settings that we can replicate?
Yeah, I would exactly. I would go back to that slide. Here, I can pull it back up real quick. I would go back to this slide here. Can you see that, Dalia?
Yeah. Mm-hmm.
This really, I think this framework really applies whether you're here at TCH with all the resources that we have, or whether you're in Khartoum and have more restricted choices on what medications you use, because this is really very well established best evidence for thinking about how to A, prevent delirium happening in the first place, but B, once a patient is delirious, trying to make them undelirious. So thinking about, is there some underlying condition? And I think this patient definitely was a great example of that, where we were sort of uncovering different things that they had along the way. We didn't know all the elements of their diagnoses until probably later in their course. So they definitely had multiple medical issues contributing to their brain dysfunction. I didn't get a chance to talk with Dr. Safwa about sort of the PICU environment and all the things that happen there. I know we struggle with noise and light at nighttime and disturbing patient sleep here in the ICU at Texas Children's. I'm sure they struggle with it there in Khartoum as well. But I think if there was one slide I would ask people to remember, this is the one. This is really the framework to think about that.
Thank you very much.
And as I said, I'll make this a PDF and send this out, and it can get distributed to everybody.
Perfect. Thank you. Any questions, whether for Nick or Dr. Hashim, or just generally about the case for our ICU providers? This would be a chance to have a discussion if anybody in Sudan wants to kind of bring up any ideas or thoughts. What are the antipsychotic medications that we can use? So risperidone is one that we typically use here, and quetiapine is another one that we use. I'm not sure which ones are available in Sudan. I'm going to ask our ICU providers in Sudan to weigh in on that. Mohammed Sadiq or Isra Tahir, do you guys know which antipsychotics are available in Sudan? I'm picking on my Jam'a colleagues.
Sometimes when we struggle a lot, we use haloperidol. This is what we have here. But usually we are not using too much antipsychotic. We try to
Thank you. Any other questions or comments from the group? I think just a few points to bring up, if you're needing to escalate sedation, if you're going up and up on sedation in a patient with, you started with intermittence and then a continuous infusion, and you're adding more than one continuous infusion, always make sure that the infusion is actually getting to the patient. So make sure your lines are working and trace them, make sure your IV works. I mean, I can't tell you how many times we actually have that problem in our ICUs, is the sedation will be in the bed rather than in the patient, and the patient's wide awake and we're struggling. So common things being common, trace your tubing and make sure your lines are working, and then consider delirium.
Another thing that I didn't really talk about in the presentation, and I couldn't really tell from when Dr. Safwa and I were working on the presentation at the beginning, but one strategy that can help with, especially for longer stay patients whose drips have escalated, is potentially rotating what opioid you're giving. I realize you're you're restricted in what choices of drugs you have, but if there's more than one different kind of opioid, can you rotate from morphine to fentanyl, or vice versa? If the patient's been on fentanyl, can you rotate to morphine? We have a pretty good protocol here at Texas Children's. I'd be happy to share it with anybody. If somebody wants to email, I'm happy to share it with anybody, but some more information on how to do that, but that can be helpful as well.
And to that point, Nick, I think that's the question that we got right now, is they typically use fentanyl and midaz and titration of the dose, but all patients will have withdrawal symptoms. So any suggestions? So I think to that point, I think our protocol might be helpful to share with the group. How we increase the dosing, and at what point we consider that the patient's kind of gotten to a max point, and we try to switch it to another agent if the patient's going to be sedated for a longer period of time. If you're getting close to extubation, that's when you consider transitioning. If the patient's been on a sedation infusion for more than 5 to 7 days, that's when we consider transitioning over to an agent that they can be on once they're extubated. So intermittent dosing. So for the fentanyl, you would think morphine. For the midaz, you would think lorazepam, so that they're on intermittent. You try to start those before you can discontinue the infusions, so that they've gotten to the patient, and then you can slowly try to wean down on the sedation and extubate the patient, so that the patient is not extubated on a large amount of infusions, and then will fail extubation. So there are different ways to help the patient get through their withdrawal symptoms, and we can share all that information. But generally, once the patient is at the 5 to 7 day mark, you have to be aware that this is the point where they're going to develop withdrawal. So suddenly stopping the infusion is not going to be helpful. If anything, it's going to make the patient withdraw. And so if you're getting close to extubating, consider starting intermittent morphine, intermittent lorazepam, bridge them for a day or two as you're wean down your continuous infusions with each dose, and then get ready to extubate the patient. But if the patient is going to be intubated for a longer period of time, and you've already titrated up on your doses on both fentanyl and midaz, that's when you want to consider switching from fentanyl maybe to morphine or to hydromorphone, depending on the availability of drugs. Any other questions?
Hi, Dalia. I had a question before, basically mainly to Safwa. I mean, to be honest, I think I can't echo enough what everyone said about the hard work and really amazing job that you've done, Safwa and the team in Gaffer, just looking after this difficult case and similar cases in really challenging and difficult resources, I would say. My question was, basically, I'm sure that you and the team felt really sad and reflected a lot on the case. What are the learning points that you can take home and share with us, especially about, I mean, I'm someone with a BEM background, all right? And one of the problems we all get is once we put a label on a patient, diagnosis-wise, that carries on for at least 3-4 days. And then basically people factor in the confirmation and diagnostic biases. How can you reflect on that? Just when things are not going the right way, should we rethink the whole situation? And again, thanks again for your hard work.
Safwa, you want to answer that?
Yeah, thank you, Dr. Khalid. Thank you very much. Actually, this was one of the learning points we had because from the beginning, we thought that the symptoms are justified by the diagnosis of pleural effusion and pleural embolism. We thought about malaria and even TB a week after, which we consider as a delay in such an endemic area for TB. That's why we should, even we had an diagnosis or a cause for the symptoms, we should investigate more.
Uh-oh,
We lost her.
we lost her. Yep. Oh, she's back. Can you unmute Safwa, please?
Sorry. Just to screen and rethink, as Dr. Khalid mentioned, about all the possible causes, not to relieve if you find a cause for a fever, for example, just screen more and more till you put off all the other causes, because you may have a multiple cause for a single pathology or a problem. That was one of the biggest learning point. Other learning point about the ventilation, we had the difficulties, a lot of difficulties actually with ventilation of this patient. We learned to just recheck the hidden or indirectly controllable measures in ventilator, like IE ratio. Just when we change the TI or respiratory rate, not to forget to check and double check the IE ratio and other measures. Not to concern about just correction the oxygen or washing CO2 on harm of the other parameter. And if you allow me, I want to ask Dr. Mohammed Sadiq or anyone to help us and provide comment on the ventilation point, because we really struggle with this in such a frightening figure of 150 and something. If Dr. Mohammed is there available, or anyone.
Still there.
Safwa, Assalamu alaikum. I think we have really a problem, because a lot of your colleagues, they are working with me in our cardiac ICU, and some of them, they are coming from the ICUs. So we expect them to have a better way in managing ventilation. Surprisingly, I feel that they are lacking a lot in knowledge and art of mechanical ventilation and settings and strategies and so on. I believe that mastering mechanical ventilation need practicing, and it's an art. It is good that the KeepMeSAFE coming course will touch on this part, and I hope we can have a good workshop or symposium or whatever, so we can improve our local people here in Sudan knowledge and practice about mechanical ventilation.
It's a great point. I think the more exposure you have to mechanical ventilation and troubleshooting it, the better you'll be at it. I think it's an art. To Dr. Mohammed's point, is you need to see more, do more, and troubleshoot more to learn it better. I think a workshop would help. I think until a workshop is set up, one thing you can do is, cases like this, we can focus on just mechanical ventilation. So if you have a gas that looks like this, and these are your ventilation settings, this is what your x-ray looks like, this is what your sedation level looks like, what would be the next step? And then we move on to another case with very different mechanical ventilation strategy, very different vent settings, very different gas. And so how do we address it this way? Because it will take some time to set up a workshop, but that's one other thing to consider. And I think the more exposure you have, the better. So simultaneously, you can have the workshop, you can do it at the bedside when you work with Dr. Mohammed Sadiq, and you can do the cases here with KeepMeSAFE as well. So the more you guys are exposed, the better it will be. Any other questions or thoughts?
Thank you. I just want to mention last point.
Yeah, absolutely.
Learning point for my colleague in Sudan. And this is a very, very important point for me because I struggle while preparing this presentation because our documentation is still handwriting and the keeping of document, because when patient is leaving, he took all his image and investigation with him. So as well, and you manage the patient properly, reminding myself and others to document every important event and investigation, because the patient most probably he will take it. And when we have a just great chance to discuss with a consultant and good people to learn more, it's a very sad story to not have the accurate and proper story for the patient. It really affects. And even when you have a proper documentation, it can trigger out a point while dealing with patient, even when he is at a hospital level. While you are dealing with patient, if you find the good documentation, you can find the hint or something to go for a better management for him. So documentation is a key for managing patient properly and ideally, and learning for further future.
I think that's very well said for everywhere, not just Sudan. I think we struggle with that here too. Documentation is key. But so I guess I'll ask a question. You can't keep a copy of the chart. If the patient leaves the hospital, can you not make a copy to keep it for the hospital? So yani patient in Gaffer ibn Auf, can you make a copy of their chart and keep it in Gaffer ibn Auf if they're taking their chart with them?
Actually, we start to have a chart for ABD and consequent change on ventilator. We try to have like systematic documentation chart to document all the investigation, not just to rely on the result paper itself. But most of the cases and most of the time, you cannot find the documentation paper printed available all the time. Just we need a small extra effort to document this. It will help a lot.
Absolutely.
I know it will be a lot for patient, dealing with a lot of patient and environment and challenges in Sudan, but documentation is important as well as managing the patient.
Yeah.
For further patients to have a better management.
Thank you, Safwa. These are great points, great learning points. Take home points. I think there's still a lot to learn. It's still a lot to work on, inshallah, for Sudan. All right. Any other questions or comments from the group?
Just I want to do a final comment, Dalia.
Yes.
I'm here in Sudan now for more than 1.5 years after I came back. I feel strongly that our setup, our people here, our pediatric intensive care services are moving forward, and I believe that with dedication of local people and help from the people outside, KeepMeSAFE courses and another promotions and programs or learning programs, it can add a lot. I will encourage the people outside from our colleague to continue this great effort, sharing and helping the people here by knowledge, by information, by education material, by discussion. And I think KeepMeSAFE, they are doing great in this part. Thank you so much.
Thank you. All right, I'm going to hand it over to Khalid and the KeepMeSAFE group from here. Thank you everybody for attending today. شكرا لكم يا جماعة، شكرا كتر خيركم كتير جيتونا وسمعتونا، وإن شاء الله تكونوا استفدتوا من السيشن الليلة.
بيرفكت. شكرا داليا، شكرا. ثانك يو نيك. And thanks for everyone who contributed, including Safwa and Hashim. Just on behalf of BSAP CH and on behalf of KeepMeSAFE Group, I would like to thank you all, and thanks everyone who's attended as well. Just a quick reminder, we've got the virtual session. It's more of virtual session will be running in about a month's time. That's more of a refreshing course with hands-on session as well that will be following. So everyone who's interested, please come and join. That would be another opportunity for us all to share such and celebrate such great efforts by our people in Sudan to contribute to healthcare in Sudan. So best of luck to everyone, and hopefully I will see you all next month. That will be the end of the session.